Ο επόμενος ομιλητής είναι η κυρία, είναι η Λουτσία Sobrin από την Ιατρική Σχολή του Πανεπιστημίου του Harvard και η διάλεξη είναι checkpoint inhibitor-induced ocular inflammation. Οπότε θα ακούσουμε την κυρία Sobrin. Νομίζω έχει συνδεθεί από ό,τι μου είπαν, αλλά μπορούμε να αρχίσουμε και τη διάλεξή της. Good morning. How are you? Thank you so much for your contribution in our Congress.
Good morning. Thank you for having me.
You will give virtually a pre-recorded lecture? Okay. So you can start. Thank you.
I'd like to thank the organizers for this opportunity to talk to you about checkpoint inhibitor-induced ocular inflammation. I'm sorry I could not be in Greece in person. I have no financial disclosures. So I'll introduce checkpoint inhibitors and then talk about the spectrum of ocular inflammation that we see with them. We'll talk about the treatment approach and then go through some cases that illustrate typical and atypical courses. Immune checkpoint inhibitors are drugs designed to treat malignancies by activating T cells against the cancer cells. They target one of three ligands, CTLA-4, PD-1, and PD-L1. These are either on the antigen-presenting cell or on the T cell. And the drugs that are currently approved in the United States are listed here along with their indications. Immune-related adverse events in general are quite common with these drugs, with the most common organs being skin, GI tract, lungs, and endocrine glands for involvement. These are most likely to occur within 3 to 6 months of initiation. Ocular side effects are seen in about 1% of patients, with uveitis and dry eyes being the most common ocular side effects. But we also see inflammation in the orbit and around the optic nerve. We're learning about the epidemiology of ocular immune-related adverse events through large databases. One thing we've learned is that when compared with cancer patients who are on other therapies that are not checkpoint inhibitors, patients who are on checkpoint inhibitors have a hazard ratio of 2.09 for developing uveitis and 2.60 for developing myasthenia gravis. We also know that patients with melanoma are at increased risk of developing uveitis as compared to patients without melanoma who are also being treated with checkpoint inhibitors. And finally, in our patients who already have a history of ocular inflammation before they start them, these patients have an up to 50% chance of recurrence of their inflammation once they start the drugs. We've also learned from these studies that there are differences between the drugs, with ipilimumab having the highest rate of incident anterior uveitis, and pembrolizumab and nivolumab having lower rates. This is a study done from the American Academy of Ophthalmology's IRIS database, showing here clearly the patients that receive ipilimumab have a higher rate of developing anterior uveitis. On the ocular surface, the most common complication is dry eye, and it can be mild, but it can also be severe and lead to ulcerative keratitis, as in this patient who developed a large central corneal ulcer. Patients can develop Sjogren's syndrome systemically, and this is something that should be checked for. Patients can also develop cicatrizing conjunctivitis and peripheral ulcerative keratitis, although these are more rare. And patients often will get conjunctival chemosis with or without anterior uveitis. Here's one of my patients who had anterior uveitis and also had persistent chemosis even after resolution of the uveitis. Orbital and neuro complications include thyroid-associated orbitopathy, dacryoadenitis, and myositis. Here is a patient from a series that we wrote up with Evangelia Papavasiliou when she was with us as a research fellow, and my colleague Suzanne Freitag on the oculoplastic service, as well as Anne-Marie Lobo. And this is a patient who received ipilimumab, and you can see his right lateral rectus is quite enlarged with myositis. Other rare findings are Toulouse-Hunt-like syndrome, optic neuritis, myasthenia gravis, and ocular motor nerve palsies. We'll focus on uveitis for the remainder of the talk primarily. In terms of the spectrum of disease, we can see uveitis at many different anatomic locations, but the most common is bilateral anterior uveitis. Posterior panuveitis have been reported as have isolated retinal vasculitis and VKH-like syndromes. It's important when approaching these patients that we broaden the differential diagnosis before jumping to blaming the checkpoint inhibitor. In particular, in these cancer patients, we need to think about metastatic disease, which can rarely masquerade as uveitis in the eye. In patients that present with more unusual features without overt inflammation, we need to think about paraneoplastic retinopathy, which can be induced by these agents very rarely. And finally, many of these patients have been previously immunosuppressed for their cancer by different cancer agents, and so infectious causes of uveitis should also be considered before jumping to making the diagnosis of checkpoint inhibitor-induced uveitis. In terms of treatment, the most important thing is good communication with the oncologist. The first line of therapy is steroids, whether it be topical, periocular, intravitreal, or systemic. In theory, systemic steroids can diminish checkpoint inhibitor activity, and so management with local therapy is preferred whenever possible. In our experience, continuing checkpoint therapy with close monitoring and treatment is successful for most patients, but there are some cases where cessation of the checkpoint inhibitor may be recommended. These guidelines are taken from this article, which is a practice guideline from the American Society of Clinical Oncology, and they suggest a transient stopping for anterior uveitis with 3+ or more cells, or any intermediate posterior panuveitis. As uveitis specialists, some of us feel that this is probably too stringent, and most of these can be easily managed without transient stopping of checkpoint inhibitor therapy. There are some cases where the clinical practice guidelines suggest permanent discontinuation, that is in grade 4 adverse events, which are defined as having resulting in visual acuity of 2200 or worse. Because these guidelines don't always match with what uveitis specialists think is needed in practice, we have convened a Delphi panel of ophthalmologists, neurologists, and oncologists to discuss the best approach to treatment for ocular complications. So now we'll go through a few cases. This is a typical case of checkpoint inhibitor uveitis. This is a 40-year-old Chinese man who has widely metastatic melanoma. He's treated with pembrolizumab every 3 weeks. After his eighth dose is when he developed floaters in the right eye. His vision was still good. He only had 2+ anterior chamber cell. He had no vitreous cell. Fluorescein angiogram and OCT were unremarkable, as you can see here. We treated him with prednisolone 4 times a day, and his uveitis resolved within 2 weeks. And he went on to receive a total of 24 doses of pembrolizumab without any further recurrence of his uveitis, and being maintained only on prednisolone every day. But not all cases go so well. This is a case of a 31-year-old man who had metastatic renal cell carcinoma. He had been treated with 6 infusions of nivolumab. At that point, he presented with bilateral blurred vision, redness, and pain, which were worse in the left eye and the right eye. He was 20/40 in the right and 2200 in the left. You can see his panuveitis. You can see the synechiae clearly here. He had both anterior chamber and vitreous cell, which was worse in the left eye, and you can see there's also some optic nerve edema. On the angiogram, there was leakage from both discs as well as leakage in the periphery. And the OCT in the left eye showed macular edema. Because his vision was so severely affected, nivolumab was stopped, and it was at first felt that we would just do this transiently. We treated him aggressively with IV Solu-Medrol and then a prednisone taper. His vision did not improve, and he subsequently received both intravitreal triamcinolone and dexamethasone implants in the left eye. And eventually his AC and vitreous cell did improve, but his vision remained quite poor in the left eye at 2200. And you can see here in these images that are taken post-treatment that he still has leakage from the disc. He still has a significant amount of macular edema and a boggy choroid. And so this, unfortunately, despite very significant treatment, did not have a good visual outcome. And this third case is a recurrent case. So this is a 56-year-old man who had metastatic melanoma to the lung and the abdomen. He was treated first with 4 cycles of ipilimumab and nivolumab, and then was transitioned to nivolumab monotherapy, and his tumors were well regressed. After his 4th dose of monotherapy with nivolumab, he developed hypophysitis and bilateral eye pain and redness. His vision was 20/20 in the right eye and 20/40 in the left. He had KP, synechia, and AC cell in the left more than the right. And here you can see his OCT showing some macular edema. The nivolumab was actually discontinued primarily because of his systemic side effects from the drugs. And we treated his eyes with prednisolone with resolution of the AC cell and the macular edema. Here you can see the nice resolution. And then we followed him every 2 to 3 months. We would be seeing him, and he had been off nivolumab for 1.5 years. His tumor was in control, and all his checkups had been fine. And then suddenly he presented with blurred vision in the right eye. And you can see he has posterior uveitis. There's a significant amount of leakage on the fluorescein angiogram, and the disc is leaking as well. And you can see he has really significant CME, more than he had at his initial presentation. And this is after not receiving any checkpoint inhibitor for 1.5 years. So we treated him with periocular triamcinolone with a partial response, and then intravitreal triamcinolone with a complete response. And this is his OCT resolution of the macular edema. And now he has had no recurrence of his inflammation almost 4 years after that uveitis episode, and his cancer has been stable and in remission. So you can see that these patients run the gamut in terms of their initial presentations, their response to treatment, and then their recurrence rate. So this last patient is interesting because there is continued effect of the drug, apparently, long after it stopped. And this is something that's also seen for these patients' cancer. So this is a graph of tumor response, and the yellow bars are a time where the patients are off treatment, and you can see that they continue to have good tumor control way after being off the drugs in many, many cases. And so the effects of these linger both for good and for bad. And the other thing to remember is that while the majority of patients present with their adverse events at the beginning, near the time of initiation of the checkpoint inhibitors, there is a tail to this curve, and patients can present 6 months or even a year out from receiving their therapy initially with their adverse event. And so we have to keep this in mind when we see these patients. And the final case I'll show is a tricky case. So this was a 64-year-old man with metastatic melanoma to the lung and brain. And he awoke the day after his second combined infusion with flashing lights and nyctalopia, just could not see. He saw an ophthalmologist who saw some minimal AC cell, no vitritis, did this angiogram, which was read as having slight peripapillary leakage and some subtle signs of retinal leakage, which can be seen here. He was diagnosed with panuveitis, retinal vasculitis, and papillitis, and treated with prednisone for 2 courses, but didn't improve, and so came for another opinion. He was 20/20, essentially, on our evaluation. We didn't see any inflammation, but he had severe constriction of his visual fields, and he had an electronegative ERG. So this patient actually developed melanoma-associated retinopathy induced by checkpoint inhibitors, which I alluded to previously. On anti-retinal antibody testing, he did have antibodies against multiple proteins, but no immunohistochemistry staining of the bipolar cells, which is what we typically would see. So in summary, checkpoint inhibitors are widely used in the management of cancer. Ocular inflammation is a rare but important immune-related adverse event that we see. Dry eye uveitis are what we're mostly going to see, but we also have to keep this in mind for orbital and neuro-ophthalmological complications. Treatment of checkpoint inhibitor-induced uveitis is primarily with local steroids whenever possible, and in the large majority of cases, the checkpoint inhibitor treatment can be continued through the course of treatment for the uveitis. However, very severe cases, treatment may need to be discontinued but that should be an important conversation to be had with the oncologist, obviously. And it's important to remember that uveitis can persist or recur even after after the patient finishes their checkpoint inhibitor treatment, and so these patients should continue to be followed. Thank you for your attention.
Thank you, Dr. Sobrin, for the given information to us. If there are some questions from the audience, anyway, the lecture was very interesting concerning the interaction between given drugs, inhibitors for cancer therapy, and interaction between the drugs and immune system reactions. There is a mystery in this combination, and exactly because this is very rare phenomenon, it's very interesting and more important to manage this situation, because you have on one hand to treat the cancer on the metastasis, and on the other hand to treat the inflammation. And this is the reaction of the immune system is so mysterious, even if we have a good experience in this topic. Any questions? No. Thank you. I did.
Thank you very much.